Good afternoon, everyone. Thank you for joining us today. After completing a readiness assessment in May, the Mississauga, Ontario Health Team was one of 31 teams in the province to be invited to submit a full application to the Ministry of Health and Long-Term Care. The application is due October 9th. This will be the first of a number of opportunities that you will have to engage with us throughout this work, including after October 9th. We hope to continue to hear from you as this Ontario Health Team takes shape. Over this session today, we want to take the time to provide you with an opportunity to hear more about the work that we've done to date. We also want to hear from you and answer any questions that you might have about the process and our first steps towards becoming an Ontario Health Team. Questions can be submitted through the WebEx portal in the chat box throughout the presentation. Please remember to include your name and organization when submitting your question. I'd like to begin by introducing you to our panelists today. Michelle D'Emmanuel, Chair of the Mississauga, Ontario Health Team Interim Governing Council. Dr. Mira Bako-Shannon, Executive Lead of the Mississauga, Ontario Health Team and practicing primary care physician in the region, and Laura Rosella, advisor to the Mississauga, Ontario Health Team, adjunct scientist, and site director with ICES and expert in population health. I will now hand it over to Michelle, who will lead off our session today. Michelle?
Thank you, Catherine. So first off, welcome everybody. We're really happy to spend this next bit of time with you to bring everybody up to speed and also to engage on the next steps around our Ontario Health Team. While we're sitting here today providing this information, I just want to emphasize that we represent some over 100 either organizations or individuals who have come together to help scope out this work. And our success to date as being selected as one of the 31 Ontario Health Teams has really been a reflection of the vast amount of work and the diversity of the groups that have been involved in getting us to this point. So first and foremost, I want to say thank you. I also want to just share that this is a journey. And while we have a steering committee that is helping us work through this at our governing council level, we are continuing to iterate and to calibrate our work and how we do our work from both just the input that individuals and our community are providing, but also from the other health teams out there as they learn and develop ideas. So it's a very collaborative, iterative journey, but it's one that, as I said, we already have had some significant success. And so over the next hour, we'll update you on where we're at, on how we see designing this next phase of work that the government has requested of each of the Ontario Health Teams, and most importantly, to share with you our findings and our data that we've been looking at around our population within our specific geography, and the early clues that that's pointing us towards as we think through how best to establish a connected, integrated system of care that really does provide health to the population. And so with that, let me introduce you to Dr. Mira Bako-Shannon, who is our executive lead, and she's going to take you through some information, and then we'll go from there.
Great. Thank you, Michelle, and thank you everyone for joining us this afternoon. I'm going to start just by recapping what many of you may know just around what is an Ontario Health Team and what is the goal of what we're trying to achieve here. And Ontario Health Teams really are designed to be integrated care systems with a focus on a couple of key areas. So that is around improving better coordination of care, better access, and allowing us just to work more effectively together. There are a few things that the ministry has put in place in the design of the Ontario Health Team that enables that. So one is looking at more creative and innovative ways that access can be achieved, including digital and virtual health. And how can we use those enablers to allow us to coordinate and connect better so that we can work in a more integrated fashion? The other things that the ministry has designed in the Ontario Health Team model is a single accountability, as well as a single funding envelope or an integrated funding envelope, and really a commitment around looking at reinvesting in frontline care so that we can continue to service the needs of the population that the Ontario Health Team is serving. And the population health parameters or conversation is really a leading one, and Laura and I will delve on that a little bit further in a couple of slides. Where we are right now in this journey around the Ontario Health Team is, as many of you know, back in April, there was a call for open assessments or self-readiness assessments. And the deadlines for those was a very tight one of May 15th. And at that point, we had many members in the community, many individuals come together to begin to conceptualize and start the conversation around what an Ontario Health Team in this area could look like. We did go ahead and submit that application and heard back on July 18th that that there were over 150 submissions that went forward to the Ministry of Health, 31 of which were selected to move on to the next phase, which is the preparation of a business case. And we were fortunate enough to be one of those 31 and are now entering into the second phase of the Ontario Health Team process. This phase really does call for a business case with, again, specific questions that elaborate on what was already addressed in the readiness assessment, focusing very keenly on how we are going to improve health for the population that we're serving, and a real detailed analysis of understanding who are the people in this community for whom we are trying to improve care. The application is due October 9th, and sometime thereafter we will be hearing the decisions from the ministry about what the next steps are following that. For those that haven't submitted Ontario Health Team applications yet, the ministry has committed that this is an ongoing iterative process. So both for those that submitted early and were not invited into business case phase, they are continuing to undergo work and connect with groups that are developing active business cases. Those that are moving on to the business case phase will have some follow-up thereafter later in the fall. And again, the ministry will be accepting first-time readiness assessments by December 4th in 2019. So the ministry has been very clear that this is an ongoing process. It's not an open and shut door. And we certainly do recognize that the conversations here have just begun and that the business case is just one next milestone in a journey towards change and integrating the system. And so one of the important things that we wanted to touch on today was around who is having these conversations. So to begin with, when the readiness assessment came forward, we had some core members that came together very early on and recognized that this was a conversation that they wanted to engage in and a commitment that they wanted to bring together for, again, the community around looking at different ways of integrating and improving care. So the initial core partners included Trillium Health Partners, home care, community agencies, and primary care in the form of Credit Valley Family Health Team, Somerville Family Health Team, and our CarePoint Health. Since that time, we have had a number of other individuals who have stepped forward expressing interest in joining us in this conversation, and we had endorsements through multiple other agencies around that readiness assessment. Again, this is not a closed door, so these conversations continue to evolve and more members are being brought on board, and we will talk a little bit about where those engagement sessions are happening, how those conversations are occurring, and where you can continue to connect into the process. Initially, though, as the readiness assessment needed to come together, an interim governing structure was put in place, led by an interim governing council with representatives from those core partners, so the hospital, home care, community agencies, and primary care. That committee remains in place through this next phase of the business case, and an appreciation thereafter that depending on what the ministry replies back, a reevaluation of what that structure will look like moving ahead will occur. The Interim Governing Council is chaired by Michelle, and that work or the development of this business case is supported by a project management office, which includes myself, Georgia Whitehead, and a number of other individuals. And together we are overseeing or pulling together a stream of working groups and overseeing an implementation table with several leads. Those working groups include a number of areas, digital health being one, and of course, clinical integration of care being the second one. The clinical integration of care we're going to speak about a little bit later on, so I'm going to pause on that. But we'll let you know that there are conversations underway as early as next week that you can all engage in if you haven't already been included in the conversations. The driver of a successful Ontario Health team really does lie in ensuring that we are addressing the care needs of the people that live in this community. And at the heart of that is really understanding who it is that lives in this community, and not just what their medical needs are, but really what are their entire needs around ensuring that we keep people healthy, that people are enjoying a sense of wellness in their lives, that those that are experiencing ill health, that we return them to health to the best of our ability, or those that have chronic conditions that we maximize their health to the best of their ability, looking not just at their medical conditions, but also at their environment, their social determinants of health, which include their housing needs, their social supports, their community constructs, and how we can start looking at improving wellness by expanding the conversation beyond just the clinical interventions that we do and really into how we as a community work better together, both within healthcare and outside of healthcare to improve the wellness. So as we look at caring for our community, we need to understand the Mississauga community and appreciate that it has a large diversity, both in terms of culture and language, with 65% of our population being new immigrants to the country. The community itself is experiencing a lot of growth, both in our seniors population, but also in our youth and our children's population. And that we do face a reality that our healthcare system here is stretched, that we, despite the growing diversity, complexity, increasing comorbidities, and just expanse of the population, remain having lowest number of long-term care beds, the lowest number of integrated primary care teams, the fewest number of hospice beds, and no mental health beds in our community at all. And yet, despite all of that, our community really does continue to deliver excellent quality care, which is a testament to the strong partnerships and strength that we have to build on as we move forward into this new landscape of Ontario health teams. And with that, I'm going to pass it over to Dr. Laura Rosella to explain to us a little bit more just around the population health dynamics and demographics of the people in Mississauga and those within our Ontario health team.
Thank you, Mita, and thank you for the opportunity to be here today. I'm really just going to take you through a snapshot of much of the data that we've been looking through in supporting this application. And there's many more data points which we won't present today, but hopefully this gives you an idea of the types of indicators and information that we're looking at. And the first one is really who our population is. And so you may or may not be aware that there's a particular attribution methodology which is being applied at the moment for the Ontario health teams. And this map really takes us through who our population is. And the methodology is really based on physician referral patterns. So it encompasses individuals, and if we just maybe want to walk through all the points to the slide, and then I can speak about it. People that live in Mississauga and receive their care here. And that means their primary care physician is based out of Mississauga, and their physician refers most of their care within Mississauga. And that accounts for most of the OHT, the Mississauga OHT, according to the attribution methodology. It also includes individuals who may not live in Mississauga, but receive their care here. Either their primary care physician is based out of here, or they're receiving most of their care otherwise here. And can also include individuals who might are not living in Mississauga, or their physician's not located in Mississauga, but again, the care is happening in this area. And so we've spent a lot of time looking through actually lots of different definitions of the population. And this is the one that we're going to focus on today because that's the focus of the application. But we are understanding how this relates to some other people that aren't included. For example, individuals that live in Mississauga but perhaps are receiving their care outside, and other individuals that actually are not tied to a primary care physician because they're either not using care or they're very low users of the healthcare system. So we're doing all of our due diligence trying to understand the population, and at this point in time, everything we're going to show you is a combination of some of those different definitions that we're applying, and that's being applied for the current definition of the Ontario Health Teams. I'll also just mention that the ministry's been quite clear that this is the attribution methodology that is a really good starting point, and it's likely, very likely, that this definition will evolve over time. So the next set of analyses are really about everything that Mita has mentioned before, which is who the population is. And we started off really with looking at population demographics and socioeconomic factors. The cornerstone to any population health approach is ensuring that whatever's being proposed matches with what we see in the population. And we know that those are influenced by the distribution of the population, immigration as one facet, but there are others, and the socioeconomic gradients in the population. And we've seen actually really important information across the Mississauga population that's really guiding the strategy and some of the decisions that we'll hear later on. So these are just some examples of some of that. The next set of data that we wanted to highlight that we've been looking a lot at are, again, risk factors for a lot of the chronic diseases that we know use most of the resources in the population. And these are factors that we know are really critical to population health. But on this slide, you'll see they also vary a bit. And here we've actually shown it by geography, which I know is quite a different way than the attribution methodology I just spoke about. But what we want to present here is that we're really looking about how these factors differ in the population. If we're thinking about a population health management approach, how we would use the different risk factors in the population to understand how we match care and need to those populations. So we have the ability to look at these across subgroups here showing by geography, and we can look at it by other factors as well. The next set of indicators really get at community and life stress in the Mississauga population. Again, as was emphasized earlier, it's really important that we understand the population from a broad variety of factors. And I know for many of the community partners on the line and watching that this is actually a big area of focus, understanding what are the factors and pieces in place that we need to put in to make sure that they're well in the community, not just in the hospital. And this really gives us a sense. Again, we've looked at it by geography, but as the strategy evolves, we'll look at it according to different groups in the population to see how well the strategy that's being proposed is matching some of these indicators. For example, self-rated mental health, how they feel in terms of community belonging and life satisfaction, which are not only important determinants of well-being, but we also know tie closely to healthcare utilization. The next set of data that we've been spending a lot of time looking at is really how the population, as is defined, is using healthcare. And this has been a really important set of analyses to give us a sense that where is healthcare being concentrated in the population, and how are the strategies that are being proposed aligning with how healthcare is being used. And these are just two different pictures of ways to characterize general healthcare utilization. So these aren't about specific conditions. These are about types of conditions, and there could be various underlying conditions that go in each category. So the first graph there that says population risk adjustment grouping is hierarchical, and what that means is that individuals are kind of grouped into one of the categories. And so that big line at the top that says minor acute tells us that there's lots of people in the population that are using healthcare for minor acute reasons, and you'll see what some of these might look like later on as we talk about specifics, but there's a large proportion of them. And this may be less intensive, less costly from a resource perspective, but there's a lot of it. So it's a really important group to look at. In contrast, you can have some other conditions, complex chronic conditions, which require lots of follow-up, very intensive, very resource intensive, and more coordination. And even though those are happening at maybe a lesser frequency, they are more costly to the system. So you can get a sense of how we have to, from a population perspective, manage all of these different pieces. What's happening in high frequency, what's high resource, and how does this map onto the distribution of the population? And hopefully that gives you a sense of some of the reasons why some of the strategies that have come up later on are showing up. The next slide is really looking at conditions. So here we're talking more specifically about the prevalence of chronic diseases and other conditions in the populations. And these tie closely to clinical areas of focus. And what we've noticed, and again, this isn't unique to Mississauga, this is found in all of Ontario and actually most jurisdictions, where we have a few very common conditions that show up in the population, and then some to a lesser extent, but also again can be resource intensive, complex. And there's integrated care implications for all of these conditions. Most individuals, especially as they age, have more than one of these conditions, and that's another consideration when thinking about the management of care. So we've been looking at not just how common these conditions are in the population, but what subgroups are they most common in? Are there particular considerations, especially with respect to some of the earlier slides around sociodemographic and equity considerations? And the last sort of data point is that, again, we're sort of then starting to get at putting all these pieces together. So what's been very clear looking through all these data points is that individuals change over time, and a lot of these conditions start to overlap, and then you can overlay equity considerations, sociodemographic considerations, and other community level factors. And so we're really trying to get a handle of how all these pieces fit together, and that involves bringing together lots of different types of data. So we've been looking at survey data, healthcare utilization data, there's data within the hospital, there's data at the community level, and then trying to put them together to try and paint that picture of the population. So I think that is it from the data side. Clearly there are a lot of detail behind these data points, and actually a lot of discussions that have led to these data pieces, and I hope that we continue to have these conversations going forward. Pass it back to you.
Yeah, great. Thanks, Laura. When we look at the Ontario Health Teams, there are three very fundamental layers in the foundation around the structure of an Ontario Health Team. And the first one is the population health focus. And so a lot of the information that Laura and her team has pulled and analyzed for us that has come to the forefront, again, understanding how do we provide, again, the best health and wellness system to the patients and people within this community. And so part of that is looking at the data analytics, and Laura has addressed some of the issues around prevalence and utilization, and also very importantly, the social determinants of health. And what we do know is that much around a person's health journey is strongly influenced by their social determinants of health, such as secure housing, the ability to afford food, the ability to afford effective child care, their education levels, as well as some of the other lifestyle choices that may impact that, such as activity levels, nutrition, smoking, and so forth. So as we start to bring these conversations together, the third element of that is around the mental health component, and really looking at, as we begin to design these clinical pathways or new ways of integrating care, we are layering in both those social determinants of health, the medical considerations, but the underpinning around the psychological and mental well-being of everyone as well, both in terms of a prevention aspect, those that are in a realm of potentially emerging risk, and those that are actually in an area of distress. And how do we actually look at that entire population and all of the layers within it? The second foundational part is this understanding that the success of an Ontario Health Team is highly dependent on having a well-formed, integrated primary care foundation. And that includes a modernized primary care system that looks at the holistic needs of a patient, that uses team-based care with everyone working to their full scope, ensuring that patients are empowered and included in the decision-making of their care, and that the decisions that are put forward are those that are value-driven by the patient themselves, and encouraging support of caregivers as well as just a general improvement around health literacy, understanding of their care needs, but also how they navigate and move through the system, and how do we support patients and caregivers to do that in a more effective way. One of the key, again, pieces underlying that is something known as an integrated continuous care pathway. And what a pathway looks like is basically an articulation of what the potential needs may be for a patient, both what they are presenting with, but also in an anticipatory fashion of what they may need in conjunction to what they're presenting with or down the road, so that we can both be preventative and proactive at managing a patient's care. It also really identifies who all the individuals are in that patient's care circle. So their core medical team, but also all the social supports, community supports, and everyone in their environment that will contribute to the improvement of their health and well-being. And how do we begin to articulate that in a way that is comprehensive, such that everybody in that care circle understands what is expected at each point in that journey, how we will relate to each other, how we will communicate, and how a patient will move back and forth along that continuum depending on what their needs are. Knowing that continuous care pathways are an integral part of this, and with the data that Laura's team has brought forward, we identified we needed to start somewhere. So looking at the multitude of places that integrated care could begin, the data working group and population health working group did sit down to look at what is the right framework by which we make a decision around where we start this journey. And we did understand that we needed to start in a place that would set us up for success so that we could learn, appreciating that this is going to be new territory, this is going to involve a lot of conversations, and having us look at things differently than we traditionally have. And so we needed to start in a place that we could do that, knowing that we will begin to layer in the other areas of care progressively as we iterate, learn, and become ready to do so. And with that, bringing in the appropriate partners on that journey at the right step as we become ready. So trying to parcel down where we begin, we created a framework that looked at impact. So some of the things that Laura spoke about around what is the impact that this will have on the goal of an Ontario Health Team. And the goals have been articulated not just around those that the partners will come together in articulating, but the ministry itself has established some evaluation frameworks by which we need to monitor ourselves, particularly in year one. The fundamental being ending hallway medicine, contributing to reducing ALC rates, improving access to care, enhancing digital frameworks. And so looking at the various clinical places that we could begin, which one of those could we have the most impact on in terms of a patient's care journey? And that included the patient perspective, the caregiver perspective, as well as primary care and all the individual partners. We also looked at feasibility and saying what could reasonably be accomplished in a year, and that was highly dependent on ensuring that there was already work underway, best practice that could be expanded, built on, or adopted from, and then also a readiness of those individuals that are required to be part of that, already engaged in a fulsome conversation. And the third part was about the partnerships and knowing that a strong partnership connection, trust and communication between those partners and existing relationships was fundamental to success. So where do we already have partners embedded in the conversation? And the three areas that have come forward are looking at people that would benefit from a palliative care approach, those with acute minor conditions, and I'll elaborate on that a little bit further, and seniors who are experiencing cognitive decline. And so we created a framework with a heat map that you're seeing on the screen right now to help us conceptualize where we begin. And we did look at the entire spectrum of the population. So everyone from children to adulthood to end of life. We looked at the various areas that Laura's team had identified, those that utilize the system intensely and in areas that may be more costly, but also those that use the system in a way that has a high prevalence or high frequency, and those where there, again, is opportunity for improvement or shift in the way we deliver care. As we looked at the 5 potential areas, the 3 that came forward looking at those that would benefit from a palliative care approach have been focused down primarily to the 5 non-oncologic areas that are included in that. It is built on the work of the OPCN. We did believe at that time that there was significant impact, high degree of feasibility because of the amount of work already done, and an interest amongst the partners to proceed in that area. The minor acute are issues that typically we see in individuals that are in their adult life, so between the ages of 29 and 59. And in this scenario in particular that we've narrowed it down to are individuals who are presenting to the emergency room department for conditions that we believe could be managed out in the community, contingent on a couple of changes in how we design the system. And our goal now is to move both of these areas into further discovery and design to really understand the key pain points underneath them, understand which areas we need to be shifting our work or changing the way we're working currently, and starting year 1 in those. With the seniors with cognitive issues following very quickly behind. Again, all of these will not just overlay how the clinical aspects intersect together, but also what are the social determinants of health, the mental and psychological components, the cultural sensitivities that we need to include as we build out these care pathways. So in terms of next steps, we have several ways that we are moving forward. So the first one is, again, around focusing on these 2 areas around starting to articulate what an integrated system may look like. We do have working groups underway that are overseeing this and invite people to join the information and design session that's taking place on August 27th. If you have not received an invite to that and you would like to be included, please let us know. Likewise, the way to reach us if you are interested in just wanting to stay informed, but not necessarily interested in joining one of the working groups or one of the design sessions at this time, is again to email us. And the email address is on your screen. It is info@moht.ca. And we will continue to follow up with you. We do plan to have a follow-up webinar such as this later in September to again continue to keep you updated on how the work is progressing. Once the application is due back to the Ministry of Health October 9th, we will again keep people informed around what the outcome of that is. So with that, I'm going to turn it over to Catherine to see if there's any questions coming from the attendees that we can answer.
Thank you, Mira, Michelle, and Laura for that very informative presentation. I would like to remind everyone listening at this time to please keep your microphones muted for the duration of the webinar. As Mira mentioned, we will now begin taking questions from our participants who are joining us today. Again, questions can be submitted through the WebEx application in the chat box. Please be sure to include your name and organization when submitting a question. We'll start today by asking a couple of questions that were submitted through the registration process. So to begin, how can we plan on being involved and engaged in the process of building the Mississauga, Ontario Health Team? Michelle?
Well, again, I think there's a number of ways people can become involved. I think Mira ended her last part of the conversation presentation with our email address, our website, where you can go on and become quite active in finding out information and putting your hand up if you would like to become involved, etc. So that's a kind of a proactive way to become involved. We have set out a course on these couple of areas that we want to begin to explore, discover, design in. And we've been reaching out to people in our various community groups that have signed on to this OHT. And we've been really engaging that expertise to come in. And we're starting to gear up, as you know, for into next week, where we'll start that active engagement and design on the 27th. So I think those are the two best ways at this stage. Keep yourself informed at our website, info@moht.ca. And also with those design teams in your various organizations, as we zero in on our areas of focus, really helping us continue to discover and design how we're going to move forward. So next week's a big week for us on this team.
Thank you for that. Our next question is, what opportunities are there for people to partner with the Mississauga, Ontario Health Team?
Well, maybe I'll start, and then Mira, you may want to make a few comments on that because you've been out and about on the road talking to so many people. So let's start where Laura really described who does this Ontario Health Team cover. And so when you look at the population, when you look at the population's needs, the partnerships are really driven from that foundational piece. And so as we look at partnerships, those of you in our community who have a role to play in the both delivery of health, but in the social determinants of health, all of that has an opportunity that can be unlocked to really advance our Ontario Health Team. And while we've talked about primary care, hospital and acute care, our community delivery agencies, really this is also about how do we unlock our partnerships with our school boards? How do we unlock our partnerships with our public health colleagues? There is endless opportunity. And what the team has been trying to do is to really lay out a game plan which is using data and evidence to lead us down into our greatest opportunities and needs, and then bring all of our community delivery arms together to be able to build out those care paths that Mira described. And we're starting at this point, but we'll just keep adding and building on it as it relates to our population. And so I would say, again, if you're involved in the delivery of services or the creation of health, then you have an opportunity in our Ontario Health Team. Mira, do you want to add to that?
Thanks, Michelle. I think the only thing I would add is that this is an ongoing journey, that although we talk about a submission on October 9th and we talk about some meetings that are happening in the next couple of weeks, this is something that is ongoing in its think, in its evolution, in its design, that this is really just a next step in uncovering what we know, what we don't know, what questions do we have more of, how will we continue to move ahead. And there is definitely a strong commitment amongst those that have engaged in the conversation to date, saying, we're gonna take a step and trust each other on working together, and know that we might have to cycle back a couple of times on this topic. And so again, wanting to just ensure that people that this is not a fixed start and stop point, that this conversation will be going on well after the business case that just outlines our current thinking is submitted. And so again, at any point that people want more information, again, any of the information sessions, the website, let us know that you're curious and we will help you figure out the best place for you to connect in.
Thank you. The next question is, thinking about people who live in Mississauga and don't have an OHIP card, will we be engaging with community agencies who support these individuals?
Yeah, sure. I'll answer that question. So this has been identified as a very, very important population, and currently isn't in the attribution methodology. This methodology is based on people with existing OHIP coverage, but we know we've certainly looked at it, at least for those living in Mississauga, and we've identified that as a key priority and strategies around making sure that we both the ministry and ourselves have strategies around this particular population.
Thank you. The next question is, where can we find information about the co-design event on August 27th so that we can contribute?
So I believe we have that information.
Code blue, emergency resuscitation, main floor. Code blue, emergency resuscitation, main floor. Code blue, emergency resuscitation, main floor.
So we do have that information, I believe, on the website. But again, feel free to email the address that has been posted, and we can forward you the details.
Thank you. Yes, I think the best way is to email the info@moht.ca, and we will provide you with information should you wish to participate in the session on August the 27th. The next question is, when will we be delving into opportunities to address the health of seniors with dementia or other populations that we know are priorities?
So I'll take that. That's a great question. And the answer is the conversations need to start soon. However, we do know that where we're starting right now, there will be a lot of learnings that we uncover through this process. So until we have started with our two initial areas and understand what the work is underneath them, we'll have a better understanding around the pace of spread and scale. So again, the expectation is that we will move as quickly as we can, so long as, again, we're learning along the way and ensuring that we're taking things on at a pace that sets things up for success for our patients and the people of the community.
Maybe Mira, I'll just add to that. As we go about this work, we really are doing two things. We're focusing on the delivery mechanisms and the pathways and the work that we need to do to care and support patients. But we're also building a system and that sustainable system that we've all been asking for and trying to create over the last many years. And so I think what you'll see is it'll feel slow at the beginning. Mm-hmm. And maybe we'll all be a little bit impatient around that. But as we get better at it, we can take on more and more and more. And so what I would say to those listening is that we need to come together and we need to bring all of our skill sets to be able to focus in on these next couple of areas so that we can really build that prototype that allows us to move faster as we continue to move forward. And so I think one can expect it to feel a little bit slow at first, but there'll be this moment where it will take off, I believe.
Thank you. A follow-up to that question, are there things that we can be doing to align ourselves so that when the Mississauga Ontario Health Team is ready to address new areas of focus, there will be more readiness?
So I'll start, and I'm sure everybody will have something to say on this one. So first and foremost, please keep involved, stay involved. If we're not providing enough information, give us that feedback. If it's too much information, give us that feedback. We need to keep this dialogue and this conversation going in a way that continues to build these relationships, these partnerships that we've had for so long, but continues to nurture them, even at times when we may not be focused in a particular area that you may be able to engage in immediately. So that would be my first thing, is we need to stay together around moving on this journey in a way that we're all informed and collectively knowledgeable. The second thing I would say is, well, we all have a dominant area of focus whether it's our mental health agency that obviously has expertise in that area, or an area that may be really focused on seniors and their issues. We also have secondary skills. We have many people and many resources in all of our collective areas that have abilities in areas like I&IT, who are thinking about digital health, who may know about human resources and how we can continue to support our people as we go through this change. So I'd ask you to also secondly think about not just what your dominant or your primary expertise is that can contribute to this journey, but also those secondary areas and skills and expertise that you can bring, and maybe making us knowledgeable about what those are so that we can draw upon them from time to time. And I would say the last way is to continue to communicate beyond this kind of communication where we're really dealing with the leaders in our community and the key delivery agents in our community, but to really go beyond that. Talk in your own organizations about what we talked to you about today. Sponsor information events. And lastly, and most importantly, continue to keep our patients and those we serve always in mind as we go about this journey to ensure that we're continuing to involve them at all levels. We have patients who sit both at our governing level and the group level, and so that's a key part of work that you can do, is continuously engaging our patients in this work.
Thank you. Our next question is, what is meant by end-of-life care, and how is this the same or different for people who would benefit from a palliative approach to care?
Excellent question. And so I know the slide deck says end of life care, but we have expanded the conversation to actually look at those individuals that would benefit from a palliative care approach beyond just their end of life needs. And the conversation on that begins very early on, right from the moment that the individual may receive a diagnosis of a life-limiting illness. And I would say even before that, around how we advise people from a preventative point of view and really take on a preventative focus. So the breadth of that conversation is the one that we are having when it comes to that category.
Great, thank you very much, Mira. The next question is, how will we measure progress? How will we know if we are being successful?
Yeah, that's a great question. I mean, the first thing I think I'll say to that is that there will be an evaluation of the OHTs, and the ministry has also signaled some initial sort of metrics by which, and that's outlined in the application, success will be deemed. And that's actually informing some of the early steps that are being taken to closely monitor that. So part of this will be evaluation that's happening outside and as part of the Ontario Health Team strategy across the province. But from our perspective, we're going to continue looking at the data as closely as we have been to make sure that we are seeing progress. And this will involve building on the metrics that are already being set out for success provincially, and thinking about some of our own metrics internally in terms of what's meaningful to us. So it's going to involve looking at the data, talking to patients, and talking to providers.
Wonderful.
If I can add to that just for 1 second, it's building on what Laura has said, is there is this framework of the quadruple aim, which really looks at saying we will know that we are doing better, that we have succeeded when patients are telling us that providers are telling us that the system is reflecting that in its metrics, and that this is something that we've created that is sustainable and can continue forward. So that's some of the framework around which we're looking at it.